Good afternoon, everybody. Thank you so much for joining me here today. This is traditional MIPS reporting. If you are a seasoned veteran of MIPS, this may be a good refresher for you. Otherwise, some of the other videos that we do may be a better option. This is back to the basics. So thank you very much for joining our call today. My name is Mike Lewis. I am the VP of Customer Success here at Healthmonix. I am running solo on this today, so if I don't get an opportunity to grab your questions, I apologize, but I will get back to everybody in a short period of time. So you can ask questions through the widget inside GoToMeeting, whether you're on the app or you're using the website. I also have the slides here for you to download to follow along if you'd like. Otherwise, after this webinar this afternoon, I'll be sending out an email with all of this information, including the slides and a video of the presentation. So everybody will get all of that this afternoon. So what are we going to cover today? Today we're going to be covering the background on MIPS, spend a little time on that, navigating the MIPS program itself, and then what it takes to submit. We're in an interesting part of the year as many people are coming up with their finishing touches for 2024, but they want to get started for 2025 as the program's becoming more difficult. Starting in the beginning of the year instead of waiting till April to get started has been something that most of our clients have been pushing for, is to get started earlier in the year. So a little bit of background on MIPS. First off, the program started in 2017. I feel like started yesterday sometimes, and I feel like it's been around for 100 years. It came with when legislated by the Medicare Access and Chip Reauthorization Act. That's a mouthful, but it's called MACRA. So MACRA created these programs. It mandates payment adjustments to providers of care for Medicare patients, as well as rewarding high quality, low cost incentives. And there are two distinct payment tracks that are becoming closer and closer linked as we move forward in this program. The first one that most of you hopefully are familiar with is the Merit-Based Incentive Payment System, or MIPS. This is utilizing 4 categories that we'll discuss a little bit later, and we're going to spend all of our time on this section over here today. The other option is advanced alternative payment models. So those are things like your ACOs, as well as there are other APMs that you could be part of that deal with quality and cost in specific ways that are different from your MIPS providers. So when it comes to MIPS reporting, what are CMS's goals? So we've had a lot of options over the last couple of years, including in 2023, where there was an optional COVID exemption for MIPS, the introduction of MVPs. The bottom line is here for you to look at, but that is what ACO reporting and where it's going for your ACOs. From a MIPS perspective in 23, there was the optional COVID exemption. MVPs were introduced this year. There is full reporting for this year, so you need to report either your MIPS CQMs or through your EHR ECQMs, or our registry can report ECQMs as well. And then there also is the MVPs that are available in 2024. Moving forward into 2025, another full reporting year for MIPS reporting, as well as it's another year that you can do MVPs, and they're adding more MVPs every single year. If you want information on the added MVPs and things that are changing for 2025, a couple weeks ago we had our 2025 final rule webinar that goes into detail about all your different options for reporting next year. I will tell you from everything that I've read, MIPS is not going anywhere. I believe, at least until 2030, it's going to be around. And I had 2 questions come across. I want to answer those real quick. Yes, you'll get a copy of the presentation. And what are MVPs? If we don't get into it in detail on here, it is another reporting option where it's less measures and more associated with the things that you do within your practice. I do have a couple of webinars that are strictly on MVP reporting. So macro and the impact on MIPS, it repealed the sustainable growth formula, changes the way Medicare rewards clinicians from a fee for service to pay for performance, streamlines multiple quality programs under MIPS, and gives bonus payments for participation in the ACO model or in the APM models that they have. Excuse me. All right. CMS objectives for reporting, promoting more meaningful participations for clinicians, and ensuring policy to continue to drive forward, giving you options as we grow and gain more familiarity with MVPs. Once again, MVPs are MIPS value pathways. It really takes into account your specialty and reduces the number of measures that you need to participate. Reducing burden and facilitating participation with APM. So that's the ultimate goal of CMS, is to get you in these advanced alternative payment models. Further advance health equity and expand coverage. I think I've read this hundreds of times in the final rule about health equity and the need for us to start thinking about healthcare differently in America and making sure that everybody has the opportunity for coverage across the map. So fundamentals of MIPS and the 2024 and 2025 programs. Once again, we do have final rules for both of those years if you want in detail look at what the rules say, but this is going to be a general overview of MIPS. So the first part is checking your MIPS eligibility. So eligibility really is the key part. You need to make sure that you qualify. So based on your clinician type, practice size, service location, you may have to report on any or all of these four categories or three categories here plus the cost category. You need to be able to you need to meet the minimum criteria for at least one of three criteria. So there is the number of patients that you see, Medicare patients you see, number of visits you see in Medicare, as well as the number of dollar amount billed to Medicare needs to be at least $90,000 in a year. So if you don't meet any one of those criteria, you can opt in, you can voluntarily report. Not sure why anybody would do that. You can opt in if you meet one of the three criteria, and you're forced to do MIPS if you meet all three criteria. Measure performances across all the categories from 0 to 100 points. Your MIPS final score will determine whether you receive a negative, neutral, or positive payment. So positive payments will be at a score above 75, neutrals at 75 exactly, and negative payment adjustments will be below 75. That is the same for 2025 as it is for 2024. Your adjustments happen 2 years after the service year. So anything that you're doing in 2024 will be calculated by CMS in 2025. And then starting January 1st of 2026, be able to start seeing on your bill, on your reimbursements from Medicare, the change in a percentage amount, anywhere from +9 to -9. It's not going to be close to +9, but the program does say. Yes, Medicare Part B only is part of this. It is only Medicare Part B. It is not just all Medicare. It does not include your MA accounts. You need to, eligibility and reimbursement are both based on Medicare Part B. However, you need to include all patients and all payers for MIPS reporting. All right, so participation options here. Individual, you can collect and submit data for an individual clinician. There's group reporting, which needs to include the entire practice or the tax ID. There's virtual group. Not many providers utilize this, but it is available for traditional MIPS only, and you can combine your information as long as you sign up for a virtual group with practices across the country. APM entity is the ability to collect and submit data for MIPS through MIPS APM. So those are the non-ACO APMs that are out there. And then something just for MVPs is the ability to report a subgroup, which means you could cut your group into pieces and report separate clinicians in different ways. I went over the eligibility a couple minutes ago. Here it is in writing, 90,000 plus in Medicare Part B charges, as well as 200 patients and 200 professional services. Reporting for 24 and 2025 are exactly the same. This is the breakup if there are no exemptions or you have to be a large practice. Small practice is a little different, and we are going to go off of that in a minute. So how does this impact you? The CMS is remaining 75 points for performance threshold. So we discussed that. Anything below will give you a negative adjustment, and anything above will give you a positive adjustment. The quality category is continuing to get harder as we move along. So you will see that more and more people are falling in that 75 and below category as we move forward. Exclusions this is actually just the eligibility up at the top. Be identified as a MIPS eligible clinician on Part B claims. You've enrolled in Medicare as a Medicare provider before 2024. You're not a QP, which is a qualified alternative payment model participant, and you exceed those low volume thresholds as an individual, which I shared on the previous screen. CMS quality reporting payment adjustment factors. So this is taken directly from CMS. As you can see, anything below 18 points is going to get you a -9 adjustment, and that slowly starts to scale up until you hit the 75-point mark, where you're going to get a 0. There's no difference. And then while this is how CMS portrays what it would look like from a positive adjustment, I anticipate that the positive adjustment will slide down and be more represented by what it was in 23, where it was 2%. So 2%, 2 to 3% will probably be the high if you score perfect. And then everything between a 100 score and a 75 score will be a positive adjustment, less than that 2 or 3%. So if you are a small practice and you do not want to report promoting interoperability, you can, but you are automatically exempt. There's nothing you need to do. You're automatically exempt from it. Then your category weights would look like this on the left-hand side, where quality will be 40% of your score, IA will be 30 improvement activities, 30% of your score, and cost will also be 30% of your score. Now, if you do not qualify for anything, any of the measures for cost, your reweightings will look like it is on the right-hand side, where IA is 50% and quality is 50%. This is a great place to be in, as IA are points that you should absolutely 100% make sure you take, as they are not nearly as difficult as promoting interoperability, quality, or cost. The cost section we'll go over a little bit later, but cost is not reported by you. It is tracked by CMS utilizing claims data for Medicare patients. If you're a large practice, the standard weighting is what we see on the left-hand side. If you are exempt from PI, not many people are exempt from PI anymore at large practices. However, there are some groups that are, including non-patient facing and so forth. PI exempt, you can see everything goes to quality. So you'll see that 25% disappear from PI, and it shows up directly on the quality side. Same thing as if you have PI and you don't have any cost measures related to you, 85% of your score is associated to your quality score, and 15% will stay in improvement activities. So you can see here how a small practice, which is 16 and under, um, will have providers, has a benefit when it comes to MIPS reporting. All right. Now we're going to jump into each one of the quality categories, or the categories for MIPS. There are 4 of them. There's quality, promoting interoperability, improvement activities, as well as cost. Some we'll spend a little bit more time on, and some we'll spend a little bit less. But we're going to start off with quality, as quality is probably the most complex, as well as the most amount of work that you're going to need to do from a clinician standpoint or practice administrator standpoint. So the performance period is the entire year. I know there is some confusion coming back from COVID that prior to that, there was, things for 90 days, there was things for 20 patients, there was lots of opportunities in the past. Now it's every payer, every patient for the entire year for the quality. For traditional MIPS, you're going to report 6 quality measures. One measure must be an outcome measure, and if one isn't available, you may use a high priority measure. For MIPS value pathways, which was discussed, it's 4 quality measures from a smaller subset. So there's usually only 10 to 15 measures in a MVP, and that's what you have to choose from. And then the same thing with if an outcome measure needs to be included. If not, they could have a quality measure. They can have a high priority measure included. Data completion is 75%. This one's always a tricky one to understand, but every single measure that is tracked has its own data completion numbers. So if you have a measure like the medication list measure, it's every patient at every visit. So that could be thousands. So let's say you have 10,000 patients. You're going to need 10,000 instances. So those are qualified visits. You'll need to report on at least 7,500. Doesn't mean that you need to report a yes or a no. It means you need to report yes, no, or excluded. That's considered complete. What's not complete is if you have denominator eligibility and there is no answer. So you need to be at least 75% data completion for each measure. So if you have a smaller measure, like 100 encounters or instances, you need to report on at least 75% of them. And the tricky part this year is that both the data completion and the minimum penalty avoidance are the same exact number, 75. So it's very confusing. Case minimum, each quality measure needs to have at least 20 patients or 20 denominator eligible instances to receive full credit. For anything less than that, you can't receive the full credit for a measure. So you can't pick a measure that you're 1/1 for, or that you have only one eligible patient that meets the criteria. That's not going to help you with your scoring. If you're a small practice, you'll get your 3 points. A large practice will get 0. New measure points. So if you are reporting one of the new measures, there are bottoms. So there are floors to these measures. 7-point floor for a new measure in this year, and 5-point if it's the second year. So there are a number of measures in the high 400s into the 500s that are new measures in 2024 that no matter how well you perform or how poorly you perform, as long as you meet the minimum criteria, you will get 7 points for them. And same thing for those measures that are meeting the 5-point floor. So you will at least get 5 points. You can score the full amount of points based on if they get benchmarks, but the minimum floor for these measures are here listed below. And these are things that you should definitely pay attention to and try to add into your MIPS reporting for this year and next year. So there are a couple different collection types for MIPS quality. There are, the one more that's here, the Medicare Part B claims. However, many people do not do those, as those measures are highly, highly topped out, and there's no real way for you to track what you're doing throughout the year. So MIPS EQM, so this is registry-based reporting. These are the ones that you're normally seeing. When you sign up with a registry like ours, they can be collected in paper charts, electronic charts, through third-party intermediaries and so forth. And there's 170 measures for 2024. For ECQMs, the big difference here is that the data needs to come from a certified electronic health record. So as long as you have a certified system and you meet the criteria, you can report on the ECQMs. You can do that through a registry like MIPS Pro, and you can report up to 47 of those measures are eligible. And there's a lot of overlap between this 47 and 170. I would say about 80% overlap. You can get better benchmarks for here, but you have no way to change any data. The data needs to be in your EHR, needs to come over, non-manipulated, and so forth. Then there's a thing called QCDRs. With QCDRs, these are specially based measures, and they include paper charts, electronic charts, third party, so very similar to the MIPS EQMs. And there's over 200 of those for 2024, and I believe a couple more as we move into 2025. That report got released, I think, in the last 2 days. All right, so the types of measures. There's a bunch of types of measures. I know we normally kind of put them all into a bucket for what they are. I went here from measures that are most popular, there are more of, all the way to the lesser known different types. First ones are process measures. They focus on steps. Did you have your flu vaccine? Did you, you know, percentage of patients, lots of percentage of patient questions. So number of patients that did X, Y, Z. That's what a process measure is. Now CMS has stated that they want to, slowly get out of these process measures. However, I think a majority of the new measures in the last 2 years have all been process measures and not outcome. They want to move more towards outcome, but those measures are difficult to get participation because they are harder. So outcome measures focus on health status of a patient and a change in that status. So you're looking at patients, for instance, that have surgical complications or hospital-acquired infections. You could look at diabetes measures, tracking diabetes throughout the entire year and so forth. Those are your outcome. Intermediate outcome, these are assessed through changes produced by a healthcare intervention that leads to long-term outcome. Patients diagnosed with hypertension whose blood pressure was adequately controlled is an example. There are patient-reported outcome-based performance measures. They're known as PROM measures. These are data that is collected directly from a patient. So this takes patient responsibility into getting the answers for those. Structure measures, these are kind of lesser known down to the right. Structure measures assess and features a healthcare organization relevant to its capacity. So percentage of patients with diagnosis history of melanoma who was entered into a recall system, which is kind of funny that CMS actually chose this measure. I took some of this information from there. This measure is gone in 2025, being replaced by another dermatology measure. Patient engagement. So this is you're administering the CAPS from MIPS clinician group survey measure. Most of this is done by hospitals and or accountable care organizations. And then efficiency measures, cost of care associated with a specific health outcome. What are benchmarks? So I try to break this down. We go pretty deep into benchmarks on a previous webinar. If you're interested, let me know, or you can visit mipspro.com, top right, or healthmonix.com in the top right hand corner. Under webinars, you will see a webinar that's about measures. Josh and Tara from my team did a very good job of breaking down everything you need to know about quality measures. But this is a little bit of an overview, which I think is good for this call today. What are benchmarks? Quality measure benchmarks are the comparison to the score of the measure you submit. When you submit a measure for MIPS quality performance category, your performance on each measure assessed against a benchmark. So I always like to say it's kind of like when you were back at school, you get a curved grade on each one of these. So if everybody gets an A on a test, it's very difficult to, give everybody an A. So someone's going to get an F and someone's going to get an A on the test. If it's going off of a straight curve. So historical benchmarks, those are used for established measures that haven't changed. So measures that didn't change from 2022 through the submission year 2024. So that if they haven't changed and they met all of the minimum criteria, they'll have an established benchmark and you'll know how to score yourself against that benchmark throughout the year and understand where you need to be to get the best score. Performance period benchmarks. These are ones that may have changed over the period of time or didn't meet the criteria for minimum eligibility. So therefore, they don't have benchmarks as you're working through the year. However, they do have the opportunity to add benchmarks if eligibility is met after reporting is done at the end of the year. So in April and May, when they're calculating this information and they see that there could be a benchmark because it meets the minimum criteria. No benchmarks. This is when neither historical benchmark nor a performance benchmark could be established. It's received no benchmark. So no historical data for it and no current data for that measure. Small practices are going to earn 3 points for those measures. Large practices will earn 0 for those measures. Topped out measures. Once again, we go into very much detail on this on the webinar on measures. Still can get 10 points, but you need to be perfect. These are measures that have a very high score for average scores from CMS, and there's not much difference between the top scorers and the bottom scorers. So normally, some of the measures, if you're not at a perfect 100% where you will get 10 points, you can drop all the way down at 99.9%. Will drop down to less than 3 or 4 points sometimes. So some of those really become topped out. The other 7-point maximum measures, even with a perfect score, if you get 100 over 100, the most amount of points that you can get is 7. It's important to understand because there are a lot of measures like that. And then we mentioned the measures about the first or second year in the program. So, I always like to tell people, you don't want to pick a new measure. Well, if you pick a measure with a 7-point maximum, right? And you pick one with a 7-point minimum, which one would you rather have? The 7-point minimum. So there are things called inverse measures. So the diabetes measure, the first measure number 1, is considered a inverse measure. So what that means is you want a lower score on these measures rather than a higher score. So for inverse measures, better performance is indicated by a lower performance rate. So there are a number of inverse measures. Just make sure you keep an eye out. If you're using MIPS Pro, bright red letters say inverse measure on there. You'll know exactly how you need to score for those. All right, quickly go over improvement activities. So I think the real thing that I wanted to share with everybody is that there will be some changes for improvement activities from 2024 to 2025. Basically taking a lot of the complexity out of improvement activities. So in the past or for this year, large practices will need to report 40 points, a combination of medium and high weighted measures. Small groups, rural, provider shortage, non-patient facing, and those doing MVPs will only have to report 20 points. So that includes medium weighted measures, which are 10 points each, or high weighted measures that are 20. However, moving forward, they took some of the complexity out and basically are saying every measure is a high weighted measure. So you only need to report 2 as a large practice and 1 as these other measures. All right, promoting interoperability. I did not go terribly in depth in this one as well, but promoting interoperability, exchange and make the purpose is to exchange the use patient information, give patients access to their data as well as providers access to people's data. This is, the big push, the secret word of interoperability that is always said, but that is the importance of this for you to be able to, as a consumer of healthcare, be able to see your information in an app or through some type of patient portal. And then as a provider of healthcare, you being able to access data on every patient that you need information on, um, across the entire country. If a patient is, traveling, or if they're going to a different practice, being able to get that information electronically instead of waiting like the good old days for a fax of the information over to you. So who is required to report PI? Groups and individuals that aren't considered small practices, ambulatory, surgical center-based, hospital-based, and non-patient facing. The only exempt clinician type is clinical social workers. However, in 2025, that is going away as well. So everybody basically above 15 providers is going to need to um, report PI unless you fit into one of those categories in the first bullet point. There are four main focuses for PI, including electronic prescribing, health information exchange, provider to patient exchange, and public health and clinical data exchange. So e-prescribing, everybody's very familiar with that. Health information exchange is the exchange of data for a patient. Provider to patient, or health information exchange is between two clinicians. Provider to patient exchange is between the clinician and the patient or a caregiver. And then the public health and clinical data exchange, that is on a larger scale basis, normally tracking a comorbidity or a disease type or something like that. There's a lot of different options for those public health and clinical data exchanges. Some of the facts for promoting interoperability for you to understand. 180 continuous days within the calendar year. So it used to be 90, now it's up to 180. You need to use a EHR technology for promoting interoperability. Must meet the certified electronic health record technology. And then the measure requirements. This is really important for promoting interoperability, everybody. If you do not claim an exemption for an individual measure, you will get a 0 for the entire PI category. You need to participate in every single measure that is required, unless you have an exclusion, and all the exclusions are laid out in the measures for you to understand. All right. Basics of cost category. Now, this cost category is much more advanced than the other categories, as insight into what you need to do, what the individual patients that are attributed to do, is very difficult compared to, knowing, hey, if this patient has a 99214, I know it needs to answer X question. So what we have here for the cost category, I go into a small detail and explanation. However, there is a greater explanation on a couple of the webinars that we've done, as well as some of the blogs that we have out there that really talk about what you need to do as a clinician to understand your cost category score. All right, so there's a total of 25 cost measures spanning most specialties. CMS is going to add more measures. I do believe this is actually up over 30 now for 2025. I have those numbers in that previous report. Basically, the idea of the cost category is CMS is determining the highest spend. They are going to track and adjust based upon patient risk for your patients, and there's a regional in there as well. Um, and what you're seeing here is that you have a category that you're not reporting. You don't have complete control over it. These patients could be seen by people outside of your organization that could still be affecting your care. But CMS's idea is that we need to take the total care of the entire patient from start to finish, and that all of those oddities will clear out as the different provider types see the patient. So CMS uses the Medicare claims data. This is more the Medicare Part B. They use a lot more of the data. There's no submission requirement for you, and then clinicians are benchmarked against all other eligible clinicians. Remember, once again, no reporting of this. If you don't qualify for any of the measures, you will automatically be excluded from the cost category. So I did want to share with everybody in 2022 with preliminary scores. I should have updated this with final scores for the cost category. We do have here from 0 to 30. I wanted everybody to understand that people are going to get every score. This is not quality reporting where, just if you do the minimum, maybe you get 15, 20 points out of it. Some people are going to get 0 to 3 points, and some people are going to get 27 to 30 points, and everybody else is going to fit somewhere in between. All right. Oh, actually, a good question for this. Can we opt out of the costs category? There are exclusions that have been available, COVID exclusion and some other exclusions that have been out there, but no, you cannot opt out of any category anymore unless you meet one of the exclusion criteria. So the submission process, I thought it'd be a good time to review this as well, as we are coming up on submission season, which starts in January and runs all the way through March 31st, where you'll be reporting your data to CMS. So how the quality category is scored, it is going to take your total available measure achievement points. So based upon where you are with the breakdown, then it takes your total measure achievement points, adds the improvement score, and that's your quality performance category score. This is for any of the different groups that are in here. Down below, if you are a small practice, there is still the 6-point bonus that you get, and then you can see how the math is done. So your total measure achievement points are added to the 6 points that are available with the small patient bonus, practice bonus, and then the total available measure points divided by, and then they add your improvement score. The improvement score is based upon how well you did in previous years compared to the current year of your reporting. So CMS figures that. And the total percentage is 100%. You cannot get higher than 100% in any of these categories. So if you are submitting this data, small practice reporting as a group and review how the data score is calculated, you can take each one of these categories. You take what your score is, right? So out of it, you take what your percentage is, then you multiply it by the amount that is allotted for that category and times it by 100, and that's how many points you get. So each one of these and the quality, you have your cost, improvement activities, and promoting interoperability. And then CMS will award you they'll reward you a complex patient bonus based on the complexity of your patients, not necessarily 3.2. That is just our example. Once again, I do say on the side here, it's really similar to your grades in school. If you have, tests and quizzes and participation, and each one of those is worth a different percentage of your total grade, and then maybe there's a little attendance bonus or something like that, that gives you the option to, maybe not do as well on the test, but if you handed all your homework in, you can make up some of those points. And that's how you are categorized. And then that 84 points that you see right here would fit you into right in the middle of, a little bit below the middle of the incentive portion between 75 and 100 points where you can get a bonus to your scores. Promoting interoperability and how that is scored. I know, I guess these slides are a little backwards. That one should have been after, but individual, group, and virtual group participation. You can see here, all of your points are added up. There are some bonus point opportunities for you. You take all of these scores out of 100, you got 92%, and then that is then divided by 100 and then multiplied by 100 in this case to give you your PI, total weighted score, and then you multiply it by the percentage that you have here. So if it's 25% of your score and you get a 92, that's how you would get your PI score. Cost category is the total achievement points earned for scored measures over the total available measure achievement points. So you take, for your cost category, you're going to look at, let's say you are available for 2 measures, 20 points would be your maximum. And let's say you get 10 out of the 20 points, that puts you at 50%. And that's how you'll get your math for how you will report, how you will get cost scored. And then you'll take that 50%, multiply it by the 30% of the actual score category that you have here, and that tells you that you'll get 15 points for that category. There's some examples here. I'm not digging into these very deeply. I kind of talked about them before, but these are for your viewing pleasure after the webinar so that you can check out kind of where you stand and what you need to do. Navigating the MIPS landscape, so performance improvement. I know we're really late in the year, but remember, if you're reporting CQMs and the data's in your system, you can count that information. So go and check what your score, check where your scores lie, figure out if you're missing information, and make the changes now. Otherwise, it's really important in 2025 to start tracking on day one, looking at your data right away, knowing what measures, doing your measure determination, finding out what measures you need to report in 2025. Those measures are out. The benchmarks won't be out until next year for them. The specifications for the CQM measures won't come out until a little bit before Christmas. So any day now, we'll have a better idea of all of the measures that you need to look at. We do know what measures are available in 2025. That came out in the final rule. You have the ability in our system to drill into your current gaps in care, see if there's any missing or improvement opportunities, really understand the look at the data and dig into it utilizing MIPS Pro. And then there are a number of free resources and tools that we have on our websites. If you haven't visited yet, well, you visited to sign up for this, but if you haven't visited our website and looked through the whole thing, we do have an ROI calculator that allows you to take a look at what the impact of your score is. We have information. Here's a MIPS reporting overview, kind of just gives you the lowdown of what MIPS reporting looks like and what you need to do. And then some of the things that we do here is improving patient care is our main goal. It's through technology that we believe we can help you as a clinician to help improve patient care, putting the right tools in the right spaces for you, maximizing your value through data, and lowering the burden of value-based care. We know it's hard, and we're here hopefully to be able to help you make it not as hard. MIPS Pro and MIPS Cost Analytics help you select measures, report, and see more into your score, giving you an option utilizing our best-in-class US-based support team and integrations teams that we have here. Our cost analytics tool really gives you an idea of what it looks like for your cost score in advance of you getting your score. And then our MIPS Pro platform has been the standard in the industry for many years now. And then complete your value-based care understanding with MIPS Cost Analytics. We talked a little bit about it, but really this gives you the ability to dig into your data, understand who the outliers are, what patients or what providers may be costing you across the board, whether through billing or through the way that their referring actions can be costing you dollars in the end. We provide a strong return on investment, 10.7% higher quality measure score than the national average. 63% of our analytics point to improvement opportunities. We help one organization with a 63% improvement in their depression screening over a year by utilizing our gaps in care and analytic reports. We are positioned for the future. Our solutions are constantly adapting to the CMS changes. So right now we have your MIPS reporting. We also have specialty QCDR measures. If you're interested in MVPs or ACOs or subgroups, those are all areas that we're really prepared to help you with. We provide the best education, including these webinars, as well as blogs that we put out there, and our very experienced account management team and customer support team here help you get and reach your goals for MIPS. We are the first registry that attacked the MIPS cost category, so you can find out more about that. And then as we move forward, you're going to realize that measures are going to change again, and we're going to be looking at what's called digital quality measures. They're the future, and we already started our development. And then, something near and dear to me, as I mentioned earlier, the social determinants of health and health equity. We believe that that's going to be a major impact on your reimbursement as well as your MIPS scores moving forward. And to let you know that we have ways within our analytics systems to check for you to have better access to what that looks like as it grows more important. There are currently two MIPS measures. One's going to be guaranteed or mandatory, on the ACO side in the near future, and I don't doubt that it will become mandatory on the MIPS side moving forward. So an example of what one of our screens looks like from a MIPS reporting perspective. This is cost showing you your estimated scores throughout the year and the total amount of scores for the year, giving you insight into that. Here's an example of our analytics side so that if you want to dig deeper into your data and not necessarily just your MIPS things. If you wanted to check things like, compare your quality scores across domains like race, ethnicity, insurance, zip codes, practices, you can do that through our analytics tools that we have. All right. All right, excuse me for that. Here we have information you can reach out to me. Obviously, I'll try to get back to you as soon as possible, but we do have a bunch of questions, and I want to see if there are ones that we can look over and go through. So give me 1 second as I'm doing that. All right, we answered. I'll go in order. I know I answered some during the presentation. The first one, will we get the presentation? Yes, you'll get the presentation later today when after the video is downloaded. What are MVPs? We explained a little bit about what MVPs are. MVPs give you the ability to take your MIPS quality and other reporting down to a level that's closer to what you're practicing within your facility. It's more specialized. They're not the greatest things just yet, but I do believe as CMS moves them forward, they'll start getting better. MIPS eligibility based on Medicare Part B and not all Medicare. Yes, it is only your eligibility is only based on it, as well as your incentive is only based on it. However, all patients need to be used if you're reporting through a registry or your EHR. 75, the performance or the reporting measure we need to achieve, it is both. So you need to meet the performance threshold as well as the individual threshold for data completion of 75% of each measure of each eligible instance. How do I find my MIPS score from last year? Oh, I got lots of thumbs up. I love that. How do I find my MIPS score from last year? You can find your MIPS score from last year by visiting the QPP site and signing in. It can show you what your MIPS score, your final score was for last year. Are small and large groups determined by MPIs? Yes, they are determined by the total number of MPIs that build under your TIN for the entire year. So you can see that if you go into the QPP site, down the bottom, if you search one of your NPIs, down the bottom, you'll see if the clinician has any of the special statuses, including small groups. Do you know the new dermatology measure that will be replaced in 2025? Yeah, if you watch the video on the final score or the final rule, I do talk about the new MIPS measure. It's very similar, but I believe it's a bit harder, but it's very similar to the recall measure. I think they just renamed that part, but it is there. I don't have it right in front of me right now, but I could get you that. My system is showing 5 points for measures 486, but we only have 5 points. All right. You need to meet the 20 patient minimum for you to get the full 5 points. I will bring that up to our team about that to make sure that that is clear in the system. You need to have those 5 points. You need to have those 20 patients. All right. How can you tell how many points per measure? There's a couple of ways. CMS does release a document that shows you the decile points that are available for each measure. Otherwise, if you are utilizing MIPS Pro, you can click on the measure itself and it will get you there. And you can take a look right there at the amount of points that are available for each of the measures. It'll tell you if it's 7 points topped out, or what your percentage needs to be to receive the right amount of points. Can you opt out of the cost category? No. What is the small practice bonus? Small practice bonus is a point for each measure that you are reporting on top of your score. CMS payment. Some people have some tough ones today. The CMS payment adjustment factor slide, it's actually something from previous. It's not exactly what last year's. I believe the top out was 2.1% that you're receiving if you got a perfect score. I would say that that's probably very similar for 2024, maybe even a little lower, and for 2025, as they're making adjustments in how some of these things go. How do we maximize our costs if we have no control over it? Well, there is the ability to use our system to get insight into what it is. And then the next step would be for you to take a look at things like your referring practices, as well as the discrepancies between each of your providers, where you stand compared to the national average for certain for each of the measures. You can take a look at how you compare to them and decide if you're doing things, if you need to do things differently. I won't give medical advice, but we do have consultants that can work with you on maximizing your cost score. But we provide the data, and the consultants will help you with workflow adjustments and so forth. There were a couple questions about specific specialties. One of them sharing that I only have measures that can do two different measures. I only bill codes that only have two measures. There's a process called EMA that you can go through that is allows you to report less. So that's something that you want to look into right now, EMA, and then you can take a look at that. Just trying to get through these. All right. I have an entire slide. Someone asked about the cost category. I have an entire presentation, as well as there are a couple of blogs on our site about the cost category. I did want to keep that at a minimum since it gets very in-depth quickly, and this was a beginner call. So I'll ask that if you want to check out our website for the webinar and be able to look at that, that would be the best bet right now. And if we'll be doing cost webinars coming up in the near soon as well. So you need to I'm going to have to look up that question. I do a question about SDOH will be required in quality or improvement activities. I do think that it's going to be included in quality. However, I think in the future it may be both. But quality may be first, because that's the direction that they took in with the ACOs. All right. I think those are most of the questions that I have here. I ask you guys, if you can, to fill out the survey. It really helps me as I'm determining what I need to do next, and we'll move from there. Thank you so much for joining today. If you have any questions, you have my information and you can reach out. Thank you very much, and everybody have a happy holiday. I'll see everybody in January.